So the first slide, I've actually pinched that off the Mick Hughes presentation, and it's out of a systematic review on ACL, post-ACL reconstruction management, and I reckon it encapsulates the phases really nicely, and I've used it as a guideline for both rehabs that I've done. So phase one, I sort of look at as soon as you come out of the operating theatre to about week 4, and it's all about getting the knee quiet. That's the term that is used. Basically trying to get swelling down, get quads going again, starting to get a bit of range back in the knee. From phase 1, move into phase 2, which is, on the slides here, 4 weeks to around 3-4 months post-op. And that's looking, I think the rep guides down the bottom are really accurate, and they are something that I've definitely applied or tried to apply in both of the rehabs that I've done, and I'm finding that they're very successful. You can't really go wrong if you stick to these sort of rep guides as a basis. So phase 2, I sort of think of that's your phase where you're really starting to master your own body weight. I think phase 2 is where you should really focus on getting good double leg and then good single leg for most of the body weight exercises. If you can nail those by the end of 12 weeks, it goes a long way for starting to load up. And then in the later stages, once you move into more of a plyometric base of rehab, you've got that base strength, that foundation to work from. So those are the 2 phases that we'll cover today. And then maybe, I don't know, in a few months or time, something we could revisit it and go through some of the later stage stuff. Let me know, or let Mark know, or Sonam, if that's something you'd be up for. So I've broken it down into sort of 3-4 week blocks. So weeks 0 to 4, as I said, really focusing on getting the knee quiet, reducing the swelling, lots of ice, lots of rest, lots of elevation, particularly the first 2 weeks. First 2 weeks post-op, most guys are really, really sore. Generally, they won't come in for physio till 2 or 3 weeks and then beyond. But if you're seeing patients that are booked in for surgery, it's a really good one to do a bit of education about what to expect the first 2 weeks. I'm sure you'll do it, but quite a lot of pain first 2 weeks post-op, quite a lot of swelling. The first week in particular, you're not really moving too much at all. I think I pretty much stayed in bed for 7 days straight. I did the exercises, which will be on the next slide, and getting up, walking to the toilet, walking back. That's about as much as you do for exercises. Purely, the pain and swelling is just so limiting. And you've got to respect that. And if you respect it, the knee will get quiet, you'll reduce the swelling. If you try and push too hard, too early, you'll blow up, you'll have persistent swelling that persists for months on end after. So first 2 weeks, or first 4 weeks, I reckon, that's why I sort of grouped it there, is really key to getting that swelling down and respecting it. Because if you don't respect it and you push too hard too early, which I reckon I did, the first rehab, once I got moving, sort of around 3 weeks, you pick up a fair bit. From 3 weeks to 4 weeks, I probably pushed a little bit too hard and then had a fair bit of swelling right through to about 3 or 4 months. So I think that's probably the most important point on this slide, and one of the key takeaways for today is when you get to that 3 or 4 weeks and you're starting to walk around without crutches and things, you're starting to feel a bit better, feeling like you can do a bit more. You still got to encourage a lot of rest, a lot of elevation, a lot of icing to get that swelling down, because it's just so crucial in dictating your next 8 weeks beyond. Couple other milestones. You probably, full active knee extension, a lot of surgeons harp on that to get that as soon as possible. Generally, by the end of the first 2 weeks, you want to be getting a full active lockout into knee extension. Getting that is important, preventing cyclops lesions and other complications down the track from developing. If you don't get that extension early, then you can delay everything fairly significantly. So they're the 2 most important. You get those done by 4 weeks, you're tracking pretty well. You're gonna set yourself up pretty good for the long run. The next 3 are not as strict. Like I said, they're the 2 priorities, but they're nice milestones to hit by 4 weeks. And the guys that are tracking on schedule, and on schedule I mean like if you're going to return to sport as an ACL reconstruction athlete or participant, generally you're looking 12 to sort of 15, 18 months. So if you were to track to that schedule, these are some of the points you want to be hitting by about 4 weeks as well. So normal gait, nil aid, obviously pending surgeon, and if it's a multi-trauma, like if you have an MCL tear or something other significant in the knee, that's going to restrict, you might be in a Zimmer splint or something like that. 110 degrees knee flexion. The sooner you can get on the bike, the better. I think I got on the bike at about day 8 or 9 this time, whereas the first time around I probably didn't get on a bike till about 3 weeks. And I reckon that had worked wonders for this time around and getting me to the point where I am now. Riding on the bike, it's next to no strain on the ACL, regardless of intensity. You can push as hard as you want and you're not going to put any more strain through the ACL than if you're just ticking over really gently. But it feels like it's the first time you actually feel like you're moving again, because you are moving again. But like it's just that first exercise where it's like I'm actually doing something for my knee and something to get better again. So that's a really nice one, mentally as much as physically, I reckon, getting on the bike. And then the straight leg raise, that's in a few different protocols. I don't know what protocols you guys use, if you use them at all. The Moon protocol for ACLs has strict straight leg raises, 20 reps as one of their criteria in their early phase. I'm pretty sure it's in the Melbourne protocol as well. And it's a nice one again. If you can get 20 strict straight leg raises, you shouldn't have any issues with a normal gait pattern. And that again gives you, if you can do 20 strict straight leg raises, it's actually harder than it sounds. You might even get a few of you doing them a little bit later, just to see what, because it's an exercise that unless you're actually going through an ACL rehab, you probably never do yourself. So it's kind of nice to get that little reality check of what your patients are actually going through when they're doing that. And if you can do that, you've got a decent amount of end range quad strength to tackle walking out in the community, no issues with no gait aid. The loading focus, predominantly a neuromuscular focus. As I said before, quite a lot of swelling in the early stages. With swelling comes a lot of inhibition, particularly of the quads muscle. So your early stages, pretty basic quads exercises. So terminal knee extension, pushing into the bed, straight leg raise, active assisted leg extension, sitting over the edge of the bed, and then shifting towards an unresisted, just using the weight of the limb. A lot of controversy around leg extensions in ACL literature and experience traditionally. Now a lot of the evidence suggests there's a degree of leg extension that's appropriate for every stage of ACL rehab post-op. There's been EMG and force studies quite extensively done in the last probably 10 years or so, I would say. and a lot of the studies are pointing towards you actually putting the ACL under more load just walking around than doing a leg extension. So if you were to do a 12 rep max leg extension test, you sit around 220 to 250 newtons of force going through the ACL, getting up to 350 just walking around normally day to day. So my advice for that's a really good one, because I reckon the leg extension is the only time that you're actually getting full quads load. You'd be amazed at how much, and as you probably know with patients that you've seen, how much you can compensate through your glutes and your calves in quad dominant exercises, like your lunges, your squats, single leg squats, all of those different variations. I was surprised, and it was this time that I really explored that. Like, you can get patients, like I think I was pushing about 50 kilos on a single leg press at about 7 or 8 weeks, which is pretty good going. And I thought, yeah, I'm smashing this, my quads are killing it. And then you go do a single leg extension with like a 5 kilo cuff weight, and you're battling by the end of like 10 reps. So it's a nice reality check, and it's nice to, it's not nice, but it's good to realise how much you are compensating and how much you can compensate through other muscles, so that you can target the ones that are really lacking. And quite often in ACLs, the quads are the ones that lack, and they're the real focus for your rehab. As for dosage, that's another one of the key takeaways for today. Getting dosages right, trying to steer away from the old 3 sets of 10 for exercises. 3 sets of 10 is good, but it's got to be an adequate resistance and load. Generally in the early stages, most of the exercises are done with either the limb weight itself or with body weight. So higher rep ranges is better. We're trying to wake up all of the muscles. They've been pretty dormant for the first couple of weeks whilst you're resting, getting the swelling down. So it's trying to get everything going again, getting that neuromuscular connection, and getting everything firing. So that is the 20 to 30 reps for each of those exercises. By the end of week 1, I was hitting about 20 reps for each one, around 3 to 5 times a day. So not doing 3 sets back to back, but I would generally break it up into morning, breakfast, lunch and dinner as a general principle, and then any time that I needed to get up to go to the toilet, sitting over the edge of the bed before I went to the toilet, that's when I'd bang out like some leg extensions, for example. Weeks 4 to 8, from 0 to 4 to 4 to 8, massive difference in the amount that you can do and how confident and good you feel in your knee again. Focus for 4 to 8 is that's when you're starting to get into your bodyweight exercises. So your squats, lunges, sit-to-stands, calf raises, glute bridges, all those sorts of exercises. I've broken up 4 to 8 as that's when you want to master your double leg variants of each of those exercises, and you want to get up to a high rep range. Generally in a lot of the protocols and literature, 15 reps is sort of a benchmark. I've found this time around that 15 reps probably isn't high enough. So I could get to 15 reps pretty early. I mean, I'm probably maybe not a unique case, but probably a less common presentation in that I'm going into a second rehab straight off the back of the first. So I've already got a fair bit of strength foundation in my legs, so it was quicker for me to regain that strength post-op. In saying that, recommendations now is to do probably 6 to 8 weeks of conservative management before going in for the ACL operation if a reconstruction is the route that you're going to take. So expectations are in that 6 to 8 weeks that you're trying to build a foundation strength, and these rep ranges and milestones are completely applicable in the prehab for an operation, and then hopefully you would hit those marks again quicker on the other side. So yeah, I've stuck at 25. That's a higher level. I want to get back to a higher level of sport. I want to return to footy eventually in a decent standard. So again, it's patient specific, as all things are. That's one of the things I hated the most at uni is whenever you ask a question of someone, the first response that always came out was it depends on the patient. It always depends, but it's so true. For the higher level athletes who are wanting to get back to a high standard of sport, I would recommend a 25 rep range for bodyweight exercises. For your weekend warrior, you may be aiming for 15 at least, but if you can get to 25, you set yourself up, as I said, for a really good loading phase towards 6 months and beyond. Similar. So again, it's that neuromuscular. Two main components are your neuromuscular and then your strength endurance. Strength endurance, when I say that, I talk about the body weight stuff, as I just touched on. So getting high rep ranges, mastering the body weight, and mastering it to a good quality. So a good quality is like a sit to stand, not just collapsing in and then reaching, really hoiking out. It's really slow, controlled back up, and then progressing to the point where you're slow, controlled, just touching, and then you're back up. Watching knee valgus not coming, collapsing in, knees over toes, slow, controlled, back up. And that's a challenge for me, like that. I'm quite tall compared to most of you guys, so that depth is a bit of a challenge for me, but I'm sure all of you would find doing it slow and controlled actually harder than it looks. Like I'm blowing after doing like 5 reps there. So yeah, mastering the body weight, quality reps, build to the quantity. So if doing those, if you can only do 5 reps slow and controlled, that's your starting point. That doesn't mean that 15, 20, 25 reps as your end point changes. You start there, build to the higher rep ranges for all of the different muscle groups. So I've deliberately ordered those in terms of the muscle groups that are probably your priorities. ACL rehab, quads, king is a common mantra. Glutes are probably the second most important. They control a lot of how your knee tracks, especially once it comes to your later stages, your jumping, landing, controlling your valgus, internal rotation. Hamstrings directly combats, it's the direct opposite of the ACL. So ACL prevents sliding forward, hamstrings do the same. So it opposes that tibial translation. So they're a really important muscle group to focus on as well. But being mindful of hamstring grafts. So hamstring grafts are quite niggly, even at 6 to 8 weeks. Like I had a hamstring graft the first time around, and I probably wasn't doing too much loading till about 6 to 8 weeks. And once I got to 6 to 8 weeks, like a double leg bridge is a pretty significant challenge when you haven't been doing much for those initial 6 to 8 weeks. It's amazing how quickly you can decondition, as I'm sure you've all seen and know. And then moving on towards calves and core exercises. And then of course, progressing to single leg variations as you start to approach the 8-week mark, and then from 8 to 12 weeks, that's when you really should be starting to hit the single leg variations of the foundations you've built on a double leg. And again, quality over quantity first. Next is a couple of slides about blood flow restriction training. Does anyone or everyone know what I'm talking about when I talk about blood flow restriction training? You've heard of it, might have seen it, might have used it. No, it's okay, like I hadn't heard of it until this time around. I was doing a fair bit. I was pretty annoyed, peeved off that I'd done my knee again, and I was like, well, how do I get the absolute best outcome and what are some resources I can implement to get a better result than I did the first time. And blood flow restriction training was one that came up. So from a strength and conditioning approach, blood flow restriction training, there's two ways that you can evoke a hypertrophy response from the muscles. So the first one is traditional resistance training. You progressively overload the weight that you're using, and that mechanical stimulus, once you start to struggle, sends messages to the brain going, look, I can't handle this load, we need to get stronger, let's build some bigger muscle fibres, let's build some more muscle fibres so that when we get those bigger loads, we can handle it. Second way, which has been probably more of a recent realisation and then evidence backed, is metabolic training. So if you evoke a metabolic stress to the muscle, same sort of response. So the whole feel the burn mantra, that sort of thing, that's metabolic stress more than mechanical. So when you really start to fatigue because your anaerobic systems are overloaded, that's when you're getting into that metabolic state. And again, it sends a similar message to the brain to go, look, we can't get enough oxygen to the muscles, so we need to make more of them so that we've got more to recruit to lift these loads. So the way blood flow restriction training works is pressure cuffs. So these ones are a Bluetooth pressure cuff. So basically like a blood pressure cuff that you would take someone's blood pressure with, portable version of those. I've got two different sorts here. So these ones are for the arms. They're a little bit narrower. And you basically, the arm ones come up and go sort of just below the deltoid insertion. The leg cuffs come up as high as you can get on the thigh without obviously going into the femoral triangle. So I generally go, if you're wearing brief undies, around the bottom of where your briefs finish for those. So basically they inflate to a pressure around about, I haven't got it on there, oh yes I do, 40 to 80% occlusion pressure. So these ones are pretty awesome. They connect to an app on your phone. So it's just a QR code, you scan the QR code, opens up the app, connects via Bluetooth to the little pump here, and then they do a calibration test, so it basically inflates until total occlusion, and then it works out what 80% is, and then it deflates to 80%, and then it holds that pressure on, and then you complete your training, your reps with an appropriate load, and then you deflate at the end. So essentially what it does is occludes the pressure, reduces dramatically the oxygen supply to the muscles. So if you think of a muscle pump you get at the end of, if you're doing, say, bicep curls, pumping them out, you get to the end of your third set and you're really starting to feel the burn in your muscle. Essentially it tries to put that pump on from the start before you even start moving a load, and then you can lift or move a significant lighter load, so around 20 to 40% of your 1RM. A lot of the time that's just body weight, and you can move that and get the same burn metabolic effect as if you were right in the last few stages of your traditional strength training. And what a lot of the research is showing is it gives you the same hypertrophy benefits. So why would you use this? In ACLs, you can't really load too far beyond body weight till about the 3 to 4 month mark. So I basically did a little bit of research, then went to Dad and said, look, done some research into the cuffs. I think it would be really beneficial for the early stage, so between weeks 4 to 12, when you're really starting to get into some more bodyweight or low load leg extension exercises, rather than sitting there and just moving for hours and hours and still getting a fair bit of deconditioning. Chuck these on, and that way, worst comes to worst, if you're not diligent, you maintain the muscle bulk that you've already got, prevents atrophy. If you're pretty diligent and progressively overload, even though it's a low load, you can still progressively overload. So, for example, leg extensions, I started off with these and a 2 kilo cuff weight. Now I'm moving 5 kilos, single leg. And that's over the last probably 5 weeks. So there's still some room, but 5 kilos with these on is a massive difference to say 15, 20 kilos. Massive difference on the pressure going through your knee, the pressure going through your muscles. But still getting the same benefits. I measured my quads circumference last night and there was a 0.5 centimetre difference between sides. I'm at 10 weeks now, so that's pretty good symmetry for 10 weeks. And I reckon that's a large amount to do with using the cuffs and being pretty diligent with it.
What would other people say that average of people at 10 weeks would be if you did muscle build?
There's always a difference.
Yeah.
You don't often see symmetry until almost 6 months.
That's right.
Yeah.
So I mean that's a massive. If it's only 0.5 centimetre at 10 weeks, like I often see 2 to 3 centimetres at 10 to 12 weeks. Like usually got chicken leg there still.
Yeah.
So that's massive. Yeah.
It's huge. And I mean, like, I can't completely just say that that's a miracle worker and that's the game changer. Like I'm honest with myself, and I know that a large amount of the regain of strength and the regain of bulk is probably attributed to the previous 12 months of rehab I've had coming into this 10 weeks. But I think I measured maybe around 3 weeks and there was about a 3 or 4 centimetre difference in quads girth. So it's pretty significant regain from an atrophied state to where I am today, and I reckon a lot of it is due to that, because aside from that, mostly body weight sort of stuff.
So how many weeks in did you start using the cuffs?
I started at week 5. So I really made sure to give myself the first 4 weeks to really get the knee settled. Week 5 is when I think I approached Dad. That would have been around week 4. We ordered the cuffs, and then as soon as the cuffs arrived, which was probably towards the end of week 5.
I think you asked me about week 2.
Yeah, there you go.
But I mean, because you've been doing a lot of research.
And then by the time the cuffs arrived, it was probably around the end of the 4th week, midway through the 5th. Saga is the brand of cuffs that we've got, and once I'm done with them, they'll be on the clinic to use. So the app's really good. It's pretty, I don't want to say foolproof because nothing's foolproof, but it's pretty close to it. When you download the app, you sign up with an email, and then it basically pre-screens to see whether it's appropriate. So it runs through all of the relevant contraindications and precautions in a checklist sort of manner, and then it'll spit out at the end, yes, happy for you to proceed, or no, go consult a doctor or clinician to see whether this is appropriate for you. Obviously when you're adding an occlusion pressure to someone's arm, leg, the key ones that jump out are people with high blood pressure, stroke risks, diabetes, all of those sort of contraindications. For those guys, definitely touching base with a GP is advisable before proceeding. But they work wonders, and I reckon there's a great crossover, not just with ACLs, but into guys that suffer from knee OA. I reckon they'd work really well, and studies show that they are pretty good with muscle bulk and training for knee OA patients.
So how much pressure have you applied for the first time?
So it's different because you've got a lot more muscle bulk in the legs. The pressure is a lot higher than in the arms. So the arm, if you think generally when you do a manual BP, you pump up to around 200 and then you release. So I think my blood pressure, if you were to measure it on the arm, is around about 120. It's pretty standard. So when I calibrated for the arm, my working pressure is 104 millimeters mercury. So it'll pump up to 104, and that's about 80%. And then like if I was doing bicep curls or tricep push downs or whatever, that's what I'd use for the arms. For the legs, quite a lot higher, because it's got to compress all of the muscle tissue and then before it gets to the arteries and the veins. So I think it's around 224 is the pressure for my legs. If anyone wants, they can download now while we run through the next few slides the app on their phone and then have a go at them. Try doing 20 sit-to-stands with those on versus 20 without them on. You'll notice a massive difference.
Do you want to go through just your standard routine that you've done at home?
For the cuffs?
Yeah, with the cuffs on.
Yeah.
Or get someone else to put them on and get them to do it. You
Yeah.
instruct them.
Yeah, so the next slide, that's what my rehab looks like at the moment. It's probably changed a little bit from when we spoke, Dad, but basically until this week, my routine consisted of single leg sit-to-stands. Oh, it's probably pretty similar. Single leg sit-to-stand, 3 lots of 15. Single leg bridge on a chair. We've worked up to 3 lots of 25 at the moment. The reason the rep range is still low for the sit-to-stand is I struggle quite a lot to get to 90 degrees in a squat. I've got quite long legs compared to my torso. I often tell people I'm 2/3 legs, 1/3 the rest. So to get to 90 degrees is quite a struggle. So I've had to work pretty hard to be able to get to 3 lots of 15 to chair height. Bulgarians, I've just transitioned back into the gym and starting to add a little bit of resistance, so that's why Bulgarians are there. But prior to that, I had a wall sit isometric for 45 seconds. Bridge hand curl, so I was doing those with just a foam roller like behind Alana, so bridging up, reaching out, reaching back in. Single leg calf raise, and then doing BFR leg extensions in the gym again, but at home I was doing a split squat, I guess you would call it. So trying to load up my effective knee more simply by just stepping the opposite forward. That way this leg's doing most of the work. So I put the BFR cuffs on and bang out the protocol. So as a part of the Saga research that they've done, their hypertrophy protocol for BFR, which with a little bit more digging is pretty consistent in other PT clinics. BFR is used a lot overseas in America. It's pretty consistent and pretty commonly used in most clinics in America. So, and a lot of those clinics use the same protocol. So the protocol for hypertrophy is 30 reps followed by 30 second to a minute rest, followed by 15, 15, 15, all 30 second to a minute rest between each set. The cuffs you inflate, complete first. The cuffs stay inflated for the whole duration and then deflate at the end. And if you're going to use BFR, generally you shouldn't re-inflate the cuffs for 5 minutes between exercises. So if you're going to do BFR leg extensions, for example, you'd inflate, go through your reps and rest, finish, have a 5-minute rest at the end of your last set, and then if you wanted to do BFR hamstring curls as your antagonist group, if you're working agonist-antagonist, then you'd wait your 5 minutes and then you'd go again.
Can you do something else in that 5 minutes? Like, could you get on the bike and tick over, or
Yeah, you could tick
so
over, or you could
just deflated, not under pressure.
Yeah. So give yourself and your muscles some time to reperfuse, have some time off occlusion. So yeah, I generally would jump on the bike for 5 minutes, not working hard, but like ticking them over with no resistance for 5 minutes is fine. Yeah. So yeah, that's what I'm sitting at the moment, and it's pretty intense. Like generally, from uni to practice, you're sort of told don't give too much because it won't get done. With your really motivated patients and the ones that really want to get back to sport, don't be afraid to really load them up. So I'm currently doing bike every morning, 6 days a week, a strength session every second day, so 3 times a week, and then an upper body session every other day. On the upper body sessions, that doesn't mean that they're complete. So I generally do an upper body session, but on the rests, like I'll have like two minutes rest usually between sets. I'll jump on a power band and do some terminal knee extension, or a band and do some banded crab walks. Pal-off press, does everyone know what pal-off press is? No, that's fine, I didn't know about it until I'd done one of these recent ones. So basically a pal-off press is a core exercise. So if you want to basically you load up either a TheraBand or a pulley weight like this one, bringing it onto tension, soft at the knees, you're not completely locked out, but you basically got the load, so the load's coming back that way, so it's wanting to turn my body to the left. You're holding, you're bracing through your core, and then you're just pushing out and in from the chest. Now this is a pretty light load, I could do this for probably 100 reps, it's not too taxing. If I were to load this up,
What time are you doing that with a power band? Like, is that
I've got a pretty strong power band,
Yeah.
like maybe like
your purple one?
the purple one.
Yeah.
But to use a cable
Yeah,
pulley machine
it's good.
is
Yeah,
just as
yeah.
good.
Just thinking at home what people do.
Yeah.
Yeah.
So that's a little bit more. After about probably 15 reps, I'd really start to feel this. And I think I've probably done about 6 or 7 now, and I'm really starting to feel it in my core, particularly the obliques, and it's really starting to pull that way.
Yeah.
The way I introduced that originally as a core exercise, but I've sort of adapted it to be a bit of a glute med one as well. So dropping the resistance and then up on one leg and doing the same. That weight is too heavy for me now. I'd probably do it with something like this. And then up on one leg, same thing. That's even too heavy for me now. But out there, working on that glute med, that single leg balance, really awesome. Particularly from a proprioception and a neuromuscular perspective, really key. Moving on. How much time have we got?
12 minutes.
Quickly, what do you reckon? Quickly run through these next couple of slides and then maybe have a go at a few of the exercises, just for a bit of a gauge to see and maybe relate to your patients a little bit more, because it's amazing how quickly you forget from going through it yourself. Like once you're fully functioning and you're not doing it again, it's amazing how quickly you forget the feeling. Like I know, like when I first started doing all of these exercises again, I was like, oh shit, I forgot how hard these were. And I'm probably closer than anyone in the room, a lot closer. Like I just finished a 12-month rehab and then gone back. So
Okay, yeah, look, I mean, anyone that hasn't had one, like you
and
don't really know
that's
unless you do it.
Yeah, exactly.
Like it's good to actually go through and do it. Sometimes doing it with people is really good to do.
Yeah.
Yeah.
The last slides are from weeks 8 to 12. Generally, most surgeons give field leave for return to running around 12 weeks. And most patients, when they do their initial research as to what they're up for in an ACL rehab, they sort of bookmark the 12-week mark as their return. Like, that's a real big milestone that everyone wants to tick. So this slide is a list of tests and outcome measures that you can do for your patients to give a yay or nay as to whether they're right to return to run. The first, and again the most important, which has already been harped on, minimum to no joint effusion, so knee remains quiet. That's the only thing my surgeon requires of me before I return to run. He said, as long as your knee's quiet, you've got no swelling, run whenever you want. And that's Julian Fowler. He's supposedly the top dog in ACLs in Australia, and some would probably argue worldwide. So really, really important, knee remains quiet. The next few are more functional, so a 30-second single leg balanced, eyes closed. Main outcome testing there is proprioception. It's amazing how much your proprioception changes after a knee reconstruction. Amazing. It was something that you sort of, when you think about it from a physio perspective, it's like dirt, but as a patient, the first time around, I was completely caught off guard by how much your proprioception changes and your awareness of your knee in space. So that's something I've been working really hard towards this time around, and something that I think probably didn't get quite good enough the first time. I'm not saying that's the reason that it went again. It was a pretty stiff mechanism of injury this way it went again, but that's definitely something that could have been better, and something that I'm trying to make sure is better.